to improve the awareness and the research and other things for diabetes in India. Dr. Tripathi is also there with us. He is a practicing nephrologist at Varanasi. Welcome, sir. He was the head of the Department of Nephrology at the Banaras Hindu University and the Dean of BHU. Excellent teacher and speaker. A great pleasure to welcome Dr. Tripathi. Dr. Agarwal is a practicing diabetologist at Pune, fellow of the American College of Endocrinology, fellow of the American College of Physicians, director of his own center, Egle Clinic, head Department of Medicine at Ruby Hall Clinic. He is a member of editorial board of BMJ, associate editor of International Journal of Diabetes in Developing Countries. But most importantly, what I've realized in the last 2 years, that what he and Bansi have done for RSSDI has been phenomenal, in getting the people together, in making all the, available on the internet and on the social media, and the awareness, and for involving all the doctors in all the activities. So welcome, sir. It's a pleasure having you here. So to kick off this, we'll have a small, Dr. Bansi was held up because of some event. So I will request the RX events team to play the small video by Dr. Bansi. Then we'll have a small 5-minute talk by Dr. Agarwal and Dr. Tripathi. And then I think because, there's so many new drugs have come, what to use, how to use, there'll be a lot of questions. So we'll take those questions and we'll go for the discussion. So if you can play the video by Dr. Bansi, please.
Hello, dear friends. I'm Dr. Bansi Sabu. And today we have in this Diabetes Nectar program of 2023, which is supported by Acmedix Pharma Company and Dr. K.K. Tripathi and Dr. Sanjay Agarwal, very close friend of mine from Varanasi and Pune. They have joined as a expert. What I'll be talking in next 5 minutes just to talk about that these two very important papers which had come. I will start initiation and then they will take it further. As we know that this paper, which was an expert opinion from Dr. Manoj Chadda and the group, who had come out, and many of my close friends like Shashank, Jyoti Dev, Rajiv, and KK Gangopadhyay, Ashok Kumar Das have written a very important paper that is the expert opinion for optimum clinical approach, a combination using SGLT2 inhibitor and DPP4 inhibitor in an Indian diabetes setting. This paper was published in 2022 and where these many experts from all over India who were the part of this group. And why this expert group was required? Because for an Asian Indian phenotype, whether this combination will be really very effective, as we know that number one biggest benefit of using fixed dose combination is the compliance, increasing the compliance. You are putting two molecules in a one tablet, and we are the country with highest number of fixed dose combination available in the world. The second biggest benefit which had come now recently is now many of these DPP4 are off patent, and one of the SGLT2 inhibitor is also off patent. And if we can combine these two molecules together, it is a very cost effective therapy for our patients using DPP4 and SGLT2 inhibitor in one. Why this expert opinion was required when we have so many molecules which had come in India in a combination form? Can we use these molecules for our patients as a first line therapy or as a first add-on, or to start with them because these are two molecules which we are adding. As we know that Asian Indian phenotype is typically of thin fat Indian. So we have a higher visceral obesity and we have multiple cardiovascular and renal risk factors which are responsible for us to get more cardiac and renal problem. This therapeutic combination may be a pertinent partner to metformin, and now we have that combination also in a triple drug formulation in providing a meaningful glycemic control without increasing the risk of hypoglycemia and improving the metabolic profile of our patients. Why this expert opinion? Again, that this combination agent with proven benefit may be preferred for patients who are high predisposed to cardiovascular and kidney disease, and this ensure long-term adherence, important aspect of clinical outcome optimization. SGLT2 and DPP4, if we combine, as we know that de Fronzo hypothesis, there are multiple pathophysiological defects for hyperglycemia and type 2 diabetes. By combining these two molecules, you are almost taking care of most of these pathophysiological defects, as SGLT2 inhibitor increases the insulin sensitivity and increases the beta cell sensitivity, and at the same time it also acts primarily acting at kidney level. It decreases the blood pressure and weight also. DPP4 is a weight neutral, but it has effect of increasing GLP-1 and GIP, which is an incretin effect, and also have a dual pancreatic effect by increasing insulin secretion and decreasing glucagon. So most of the, along with, if I put the metformin, which is a insulin sensitizer, you can say that these three molecules almost taking care of all 8 important pathophysiological defect of hyperglycemia in type 2 diabetes. There are 5 solid reasons that SGLT2 and DPP4 inhibitor is a in fixed dose. It is a suitable option for Indian type 2 diabetic patient because of its safety, rapid and sustained glycemic control. It improves both insulin resistance as well as beta cell function, so improving insulin sensitivity. It helps reduce body weight and blood pressure too. That's an extra glycemic benefit. It reduces pill burden. That's an adherence and compliance improvement. And finally, it also have overall cost effective also. In treatment-naive patients with type 2 diabetes for whom metformin is contraindicated or who are metformin intolerant or HbA1c is already higher, they can be put this combination even without metformin also, as we know that now SGLT2 inhibitor with the patient with established cardiovascular disease probably a preferred choice before metformin in patient with cardiovascular disease. So with the final words which is been used in this expert opinion by multiple experts from over India, we have with us Dr. Sanjay Agarwal and Dr. K.K. Tripathi. They will be talking more about this paper in their discussion. Then we have one more article which is recently published in JAPI 2023 issue, which is talking of simplifying type 2 diabetes care with a linagliptin, a position paper by Dr. Amrish Mittal and by Dr. Ramchandran. They also included other experts, Dr. Bhattacharya, Manoj Chadha, Mala Dharminglam, and Devlia Senial. It is 87 KOLs from all across the country. They had put 16 questions, and this was that how linagliptin is more effective. So the efficacy of linagliptin is comparable with other gliptins. Yes, we all know it has better efficacy across the Asian population. That is what 78.5%. It is better efficacy. Linagliptin has best renal safety in compared to other gliptins. We know about it, and linagliptin can safely be considered in broad patient profile, including elderly patients. So you have efficacy comparable with other gliptins. It is more efficacious in Asian population, found to have more renal safe that we know, and can be used even in geriatric population also. So in conclusion, linagliptin therapy is simplifying the management of type 2 diabetes because a one dose, same medication can be used in a patient with renal dysfunction and can be for a good efficacy and used in across a wide range of patients without any dose modification. With this, I thank and I give now to Chairperson Dr. Ishwar to take it further for discussion. Thank you very much once again, Acmedix, for giving me this opportunity.
Thank you, Bansi. You have sort of set the ball rolling, and you talked about this topic which you are going to discuss today. I would like to ask Dr. Agarwal to comment, because you rightly said that ours is a country with a maximum number of fixed dose combinations. Yes, a few of them are irrational, as Dr. Agarwal would rightly agree, but lots of combinations have definitely reduced the price and the cost, the pill burden and the price. Both these things are very important for Indian patients, because we have to understand that 80% of our patients are those who cannot afford the medication. And the pharma industry in India has done a big, if you compare the prices of medicines abroad, you will find that there's a huge difference, and people in India are paying much less for their therapy. So if Dr. Agarwal can, please add something about the fixed dose combination. I'll then go to Dr. Tripathi to talk about, the DPA, SGLT2 and renal. So what is your take on so many combinations which are now available in the market? What do you think is the best thing to do, and how much is it helping the patients with diabetes?
Thank you, Dr. Ishwar. I think it's a very important sort of issue that needs to be discussed. We know that compliance to treatment is a very major issue today. And we obviously, when, any patient with diabetes, if you look at their prescription, they've got multiple drugs. And often, patients get fed up of taking so many drugs and tend to stop some of them on their own just to reduce the amount of pills that they need to consume. Having said this, that may become one of the major reasons why patients may develop uncontrolled hyperglycemia and a high HbA1cs. So we need to obviously see how we can make better compliance and adherence to therapy, and because of which I think fixed dose combinations have come to stay. And to a larger extent, if you look at across the prescription patterns, we do find that doctors as well as patients are opting to use fixed dose combinations. The only question is, of course, we need to be very certain of the rationality of the fixed dose combinations that we tend to have. And if you look at the current combination of, linagliptin with the SGLT2 inhibitor, we are very sure that this is a very rational combination from the data that has just been presented to you by Dr. Bansi Sabu. We now need to, of course, understand where do we position use of this drug very importantly as a fixed dose combination. We obviously, as Bansi pointed out to you, that it is excellent in glycemic lowering and improvement in the HbA1c values. We also use it for reduction of cardiovascular risk, as Dr. Tripathi is going to talk to you about it in a short while. It is also good to use in patients who are prone for hypoglycemia, and we want to see how can we use combinations which will protect them from hypoglycemia. And largely, of course, we can use these combinations early in the course of the disease, particularly in patients who are obese, having a high A1C values, and we want to see can we combine the effects of glucose lowering with weight reduction. And if we can get these dual benefits, then this combination will be a very rational combination to use in our subsets of patients. The data is all there, and obviously we want to see that how best we can utilize this drug effectively. A large part of the effect that comes from the SGLT2 inhibitor, which is supplemented by the DPP4, has now found wide acceptance, and it is supported by large-scale clinical trials. So I'll stop here and ask Dr. Tripathi to continue. And I think it's a great combination. We should use it. And it is something that, doctors will find merit to get their patients to adhere to the combination and keep the A1Cs well in control. Thank you.
Thank you, Dr. Agarwal. Dr. Tripathi, on your take, I would like to ask you that dapagliflozin and, all this being off patent and being available at, with so much of pleiotropic benefits which are there to the patient, available at such low price in fixed drug combination so that the number of tablets, the pill burden is not increased. How much of difference has that made in your practice? Can you please say a few words about that, about what is your take on this FDCs?
Wonderful. Thanks to Acmedix for the cost on which these SGLT2 inhibitors are available. We are the happiest people because my 97%, maybe 99% patient are extremely poor and couldn't have afforded that time it was launched with the EMPA and canagliflozin combination about 10, 15 years before. So it's very much acceptable. And because it has a pleiotropic effect, we have become very confident in using and writing it. Nephrologists have known this molecule at least 30, 40 years back. While when I was doing my DM, this was a very, very important scientific deliberation as how come the interstitium of the loop of Henle maintains the tonicity. Because when you double up, keep on multiplying from the bottom of the loop, going to the top, to the proximal, to the distal tubule, there is a stepwise dilution. So there was a question, this is called iso-osmolar movement of the molecule, so that they can produce a solute drag and a solvent drag within the interstitium. We did not understand that, and it was very difficult to answer. Today, now we know that is where all SGLT2 receptors primarily, which are important, and they prevent the absorption of the sugar and the sugar goes out in the urine in healthy individual if it is more than tubular maxima. So the advantage of these molecules made a fantastic change in the concept that it prevent the absorption, which the expression was increased in the type 2 diabetic patient at the proximal tubule. And it has advantage that it prevents the absorption. So hyperglycemia is taken care of. More sugar is available in the tubule. So there's more water drag. So to a nephrologist, this is a boon because we get rid of water logging, which is part of the diabetes. We get rid of sodium, which is also gets absorbed along with the glucose. And it has got a sodium hydrogen ion exchanger, that quality. It stops. So sodium is also gone. Therefore, it takes care of blood pressure also. And also because of the water load is reduced, sodium load is reduced, it reduces the burden on the heart. Means the diastolic volume, the right ventricular diastolic load also become less, and thereby the pulmonary pressure, wedge pressure also becomes less. So these patients can breathe better. So it helps in the cardiac also. So to a nephrologist, all these patients who had a type 2 diabetes and had a diabetic nephropathy, initially part stage 2 to 3, this drug has proved wonderful examples and said, and it has helped in taking care of the water logging, left ventricular failure, improving the ejection fraction, improving the edema, and improving the hypertension because of the drop in the sodium. All these are the 4 advantages, apart from many other advantages. So since this molecule has become now very cheap, is available, as cheaper as glimepiride or any other molecule of that particular range, it is affordable. We are very comfortable to use this molecule, especially in those patients who have got associated renal failure, stage 2 and 3. 4, 5 is little controversial to the nephrologist, in spite of DAPA CKD and trial of there is still debate going on at the molecular level. But anyway, to the clinician, this is a good molecule. We feel very comfortable. And it takes care of the extra sugar load without hurting the beta cell or without hurting the functional capacity of the beta cell. That's the one advantage.
Okay, thank you, sir. Now going back to Dr. Agarwal. Dr. Agarwal, are you online?
Yes,
Yeah.
I'm there.
So just a hypothetical question. We all know that the Accord Advance and VADT trial showed that tight control of sugar does not give the desired results. Maybe there are so many reasons. They said that population was not chosen properly and hypoglycemia was more and all. But suppose we have such a combination. Somebody has the the idea to do a trial with a DAPA, LINA, pioglitazone and metformin, and the same type of trial is repeated a little bit earlier in patients who are still early in their diabetes. Do you think that, I mean, it's just a hypothetical question. Do you think that with all these pleiotropic benefits of these drugs, the cardiovascular outcome may change and we may find a totally different result from what we saw in the Advance and Accord and VADT?
So, I mean, it's a very interesting question that you put up. It's just the answer to this is just depends on which stage are you, introducing this drug. If you're introducing this drug as a prevention, then obviously it's going to have the benefits. Because we know that, at the time of diagnosis itself, a macrovascular complications is conglomeration of a multiple risk factors, whereas, and it's independent of only glycemic control. Whereas if you look at microvascular complications, it's more dependent on the glycemic control. And we obviously now talk about screening for microvascular complications even at the time of diagnosis. So if you're trying to reduce the macrovascular complications burden, then you have to start these combinations early because each one of them has got good data in terms of outcome trials, whether you look at pioglitazone, whether you look at, whether you look at DPP-4 inhibitor, dapagliflozin, and as well as DPP-4 inhibitors. More or less, the cardiovascular risk is neutral with DPP-4, so the benefit actually comes more from the SGLT2 inhibitors as well as the pioglitazone. Metformin again is rather neutral, and we don't have too much of great data in terms of CV outcomes when it comes to metformin. Now, if you have already got an established cardiovascular disease, it remains to question how much are these combinations really going to benefit once the horse has already bolted the stable. So you have to sort of pick your patients early, identify the cardiovascular risk factors, and see that before they develop cardiovascular disease, can we reduce the risk burden by using these combinations, both from a dual angle for reducing the glycemic status, but as well as addressing the cardiovascular risk conundrum.
Thank you, Dr. Agarwal. Dr. Tripathi, we do have ACE and ARBs, which we can prescribe, in a patient who's having proteinuria, and we also have finerenone, which is available. But both these drugs cannot be used till, unless the patient is hypertensive or having proteinuria. I mean, it cannot be used as a preventive drug. But in a newly diagnosed diabetic, we can always be using DPP-4, SGLT2 inhibitors as the first choice. And now, gradually, we are going towards guidelines where people are saying that you please use SGLT2 along with metformin or, as the first drug for these patients. Do you think that by, because obviously we can't use ACE inhibitors or finerenone in patients who are not having proteinuria, but we can use SGLT2 in any stage of diabetes. Do you think that by starting SGLT2 early on, not only are we preventing the complications from occurring, but it's likely that these people will not need ACE inhibitors or finerenone later on in their lives?
This is a difficult question. See, ACE inhibitors mechanism of action is entirely different because it takes care of your renin-angiotensin, which is a part and parcel of the system of the physiological stabilizing these patients once they develop hypertension, number one. Number two, there is long history of the ACE inhibitor right from the day of Mogensen, from the captopril, then to the losartan, and then to the different sartans we have. And then we have ARBs also. ACE inhibitors have been there for more than 3 decades, now 3.5 decades. Sartans have been little later. So the property of decreasing proteinuria has been documented more with the ACE inhibitor, even without affecting the blood pressure. When you look at the HOPE trial, there was only diastolic drop of 5 to 3 millimeter mercury with 2.5 to 10 milligram of the ramipril. On contrary, the on-target trial and other trial which have showed little more drastic reduction in the blood pressure, the sartans like ARBs have not shown that property. But when it comes to the looking at the myofibroblast into the cardiac myocyte, which is responsible for early diastolic dysfunction, then late reduced ejection fraction. That is a long story. So they work on the myofibroblast. They also work on the fibroblast growth factor to prevent and establish the cardiac remodeling. That advantage have been shown established with the ACE and ARBs. On contrary, SGLT2 inhibitors are now being used by the cardiologist. And cardiologists are using it not because of the glucosuric property, but they are using it as a preventable property for the better perfusion and for better maintaining of the ejection fraction. So that's the 2 advantages. So I don't think that ACE inhibitor and ARBs would not be used and SGLT2 inhibitor will be continued. We as a Dr. Sanjay is also, and Banshi is also from the same, we look more patient also come to us for the hyperosmolar symptom and glucosuria, and they have a problem of the hyperglycemia, and they always look at the values. But it is true when the patient's GFR start decreasing and it comes to stage 3, 4 onward, then probably the action is not responsible. The glucose lowering property is not that very important. It's the non-glucose lowering property. I said in the beginning that the sodium hydrogen exchange is more important issue there, and the cardiac remodeling and on the fibroblast growth factor. So what I feel personally, ACE inhibitors have their own role. in taking care of the cardiac remodeling, prevention of the hypertension, taking care of the ejection fraction, and have a more cardiovascular favorable data available with us. But certainly, they are additive. But only one question, and this is repeatedly being discussed in the nephrology forum at different places. You combine the two, and once eGFR falls at the stage of 4 onward, means it is less than 25 or close to, then probably both drugs have some disadvantages. And they might, initial phase, they would decrease the eGFR, serum creatinine will go up, patient will always be coming to you asking that his creatinine has gone up. So you ask them to wait for another 2 to 3 weeks before it starts settling down. But the two combination, then probably one of them has to be withdrawn. We usually hold on the ACE and ARBs, let the SGLT2 continue for some time. And the moment patient reaches to stage 5 and the stage renal failure, ESR is less than 10 ml, we do not use any one of these drugs.
Thank you so much, sir. Dr. Agarwal, when the gliptins were all under patent, somebody came up with teneligliptin, which was a boon because it was so cheap. Now that all the gliptins are off patent, Lina is also off patent, Vilda is off patent, Sita is off patent. How early should we start, and what is your choice? Is it linagliptin, or how do you choose which gliptin, how early to give, and how much of difference has it made that all these drugs are now become off patent in your general practice, in your prescription in patients with diabetes?
I think essentially you need to see that, all these drugs have they address different pathological pathways to diabetes. By itself, the DPP-4 inhibitor as a class has a very sort of modest lowering of the A1C. So if you look at it, A1C lowering by DPP-4 inhibitor by itself would be to the tune of about 0.6 or 0.8%. Combinations are better. And we've got, of course, if you look at the verified trial, we've got that early combinations would sustain the A1Cs to better control and probably delay the time to intensification. So we need to see, can we start these combinations with DPP-4 inhibitors earlier? Is there a distinct advantage of one over the other? Biochemically, yes, you can say that one is, there are many properties that distinguish one from the other. But in clinical parlance, if we look at it from our own usage in clinical practice, we find that to a major extent, they have very similar roles to play, and they have very similar outcomes when we use it in clinical practice in our patients. Yeah, there is an advantage that, if you use linagliptin, it is once a day, which becomes a kind of more acceptable, and you're able to use that as a combination therapy with dapagliflozin, giving you the choice that you can use it once a day and not twice a day. Also, the dose modifications are not so much required, as Dr. Tripathi just pointed out to you. And these are distinct advantages that you can see with these combinations. There are distinct roles that these combinations can play. For example, DPP-4 inhibitors are good to use in the elderly population where the risk of hypoglycemia can be high, and that may become the preferred, agent to use. It's good to use as an add-on agent when you find that, your one drug, two drugs are not getting to your goal and you want an additional drug and you want a supplemental effect, then there's a good to use, to get the additional benefit. And you've seen earlier that combinations have better A1C lowering than single agents, and that may become beneficial to use when you're getting that just an additional requirement to bring the A1C down to control. So I think it's a great drug. Just use it in the right format. If you want to you want me to say that, okay, is it the primary drug to use? I would say no. You have better drugs which address, your cardiovascular risk or renal risk and, weight risk.
Thank you, Dr. Agarwal.
For hypoglycemia.
Role, but to gradually, to talk about a chronic renal replacement therapy. Do you think that by adding SGLT2 early on, this trend will be reversed? That patients, will have a better period of life without going in for renal failure. Do you think that it has changed the way, that nephrologists will be seeing the patients who are having diabetes in the future because of the addition of this drug early on?
You want me to answer?
Yes, sir. Dr. Tripathi, I want you to answer.
Yeah. See, still, I'm a little old-fashioned physician and a traditional nephrologist. We had dropped many newer molecules. They came with a making big noise, like direct renin inhibitor came in the market and then thrown away because of the limitation. Many molecules have come and they did not look the day of shine of the day. But it's equally important. All these trials, CKD, DAPA CKD, and then EMPA, the CKD trial, and the Carolina trial, Carmelina trial, all these trials where the linagliptin was part of the component, they have given all the advantage of any gliptin. Linagliptin has few advantage over the other gliptin, and I think I must tell you here that experimentally they have shown to have advantage on the epidermal growth factor, which factor works in bladder mucosa and the renal tubule. So this growth factor prevents the addition of bacteria into the bladder wall and the urogenital mucosa. Therefore, one of the advantages reduce the incidence of the mycotic infection and UTI. That advantage was linagliptin. The second advantage apart from that was, like any gliptin, as Dr. Agrawal said, that it is incretin-based therapy. So the good part would be that they take care of the glucagon. What happens when we use as T2 inhibitors, initial part, there is artificial fasting state. So with this artificial fasting state, the GLP goes, this glucagon goes up, and we want to down the glucagon. We don't want to continue it for the time. So a combination makes a good friend, and then they are complementary to each other. So two advantages. So gliptin is a very physiological way of treating these patients because of taking care of the incretin effect. Likewise, SGLT2 inhibitors is equally good. But what we all feel that both of these two combination, the patient has a lot of hyperosmolar symptom. Glucose is very, very high. It takes little time. In all these studies, which I was referring to, EMPA-REG, as well as these DAPA CKD, all these trials have shown their result. Statistically, they said since the result has been become, so the trial was stopped. So all these results have come between the gap of 3 to 4 years, minimum 2 to 3 years, or some has gone 3 to 4 years, about 45 or 60 weeks. We do not have long data available, safety data available, and compromise, because we as a nephrology, we feel 10% of functioning nephron you drop every decade of life. So if somebody is diabetic, now we see in younger patient, lot of younger patient, and that's the rationale to what Dr. Agrawal was talking, that you should start early intervention. If you use it at a very late stage, when there's already functioning nephron have gone, probably it would not have the beneficiary effect. And because you have lost number of nephron over the period, so 3-4 year data doesn't give you substantial. It may give for the publication that you show that the values are very high. But if you look at the UK PDS data, old data, even metformin have shown the favorable effect on the cardiac functions about 35 to 36%, what empagliflozin have showed to us in that EMPA-REG trial. So what I mean to say that still we need to wait, look at the results, the hardcore data, the statistical data are good, are very supportive. We should continue to and see little more number of years. The only problem is in all these patients, diabetic patient, it's a progressive. Diabetic kidney disease is a progressive disease. Whatever you do, you take care of the hyperglycemia at the very early stage, you give a good lease of life. But once they develop nephropathy, whether having proteinuria, like you said, Crendia, Finerenone, it's an entirely different mechanism of action. And I agree with Dr. Agrawal. You cannot extrapolate these two. They work entirely on a different way. But certainly, they reduce the proteinuria. They work on the podocyte. Gliptins take care of the podocyte on the filtration fraction, at the barrier, at the slit pore, and thereby they do reduce proteinuria. So the mechanism is a little different, and they cannot be totally. We cannot extrapolate the result, one result to another result.
Thank you, sir. Dr. Agarwal, this combination of metformin, dapagliflozin, and segliptins, how much has it changed your prescription pattern? Initially, we had, always we used to add sulfonylureas because of the cost. It was cheap and it had a good HbA1c reduction. And it was a favorite of all the diabetologists because sulfonylureas were so cheap in India. We were always worried about the hypoglycemia and the gradual loss of beta cells when we use sulfonylurea. How much has your prescription pattern has changed that when you see a new diabetic patient? Obviously, with an HbA1c of 10 or 11, this combination is not going to work. But a large chunk of patients who come with 8 or 9 HbA1c, how many patients have you stopped using sulfonylurea and now you're using this type of combination as the first drug or the first tablet in these patients?
So I think I don't think I have any hesitation to say that our prescriptions have changed considerably because of the wealth of data that is available with SGLT2 inhibitors as well as DPP4, particularly dapagliflozin and linagliptin. I mean, we have a huge amount of data that is now available in terms of cardiovascular benefits, in terms of renal benefits, adiposity benefits, so many benefits that have been coming out. And every day you have a couple of papers that come out in different journals outlining. Now, becoming generic has been a big boon because we now can use it and it's become affordable to use it as a frontline treatment. Earlier, sulfonylureas, of course, were, as you rightly said, we used to use it a lot. And majorly, it was for two reasons. One, the glycemic lowering and the cost advantage that we tended to have. But if you look at the data, there hasn't been great data of outcome data with sulfonylureas when you look at the benefits as such. Now, of course, we have moved a lot away from just glycemic lowering to say that what are the comorbidities that will benefit if you use these combinations early, which the sulfonylureas do not have any significant data about. So I think I can understand where you're coming from, because if you look at the prescription patterns across the country, even today, sulfonylurea metformin combination probably maybe the highest selling combination. But if you're looking at a rational combination to use in patients who are going to get long-term benefits, then I think we have to move away from sulfonylureas to use these drugs because they are now generic and they are affordable. And we should give the advantage to our patients to have these drugs earlier on in the course of the disease.
Thank you, sir. Dr. Tripathi, one question. Let's see, we are practicing diabetologists, and when our patients have complications, they come to you. What is your advice to the physicians and diabetologists? What should they do so that the onset of renal with all these new drugs available? What do we need to do to sort of reduce the number of patients who are coming for renal care? Obviously, it is going to happen over a period of time. The longer they live, it's going to happen. But what can we do about that? Just before you answer, I think Dr. Agarwal wants to leave. So, Ajay, if there are no other questions, if Dr. Agarwal wants to leave, then we'll let Dr. Tripathi answer the last question, and we can say goodbye to Dr. Agarwal because he has got some other commitment.
Sure, sure.
Right.
Thank you, Dr. Agarwal. Thank you for joining.
Thank you very much. Thank you, Dr. Tripathi.
Thank you so much.
Nice meeting you, and thank you, Dr. Ishwar.
Thank you so much.
Sir. Thank you so much from Acmedix.
So, Dr. Tripathi, what can we do as physicians and diabetologists to reduce the burden? And of course, we want the patients to live a longer and better life without having to undergo dialysis or RRT or whatever is needed. So, what is your advice to the people who are going to practice? What do they need to do?
It's like doing the 3-stage prevention: primary prevention, secondary prevention, tertiary prevention. So the primary prevention starts, they do not have nephropathy to start with. But if you look the natural course of the disease, the microangiopathy starts about 8 to 8 years before you make a clinical diagnosis of diabetes. The macroangiopathy could be little later, but they present entirely different. Microangiopathy can present in the form of proteinuria, albuminuria, microalbuminuria. Macro can present with the coronary event, with the peripheral artery disease, with the stroke. And sometimes these macroangiopathy could be the very fatal. Whereas proteinuria, just microangiopathy is not that fatal. It's a progressive. And therefore, as a part of now primary prevention for kidney disease means you should do intervention as early you pick up. So the first thing would be to do a urinary albumin excretion. We should tell all diabetologists, internists, endocrinologists who are seeing the patient, please do first screening when the patient is coming to you. Do a urinary albumin excretion. At least you assess what is happening at the level of the tubule. Second is the glomerular injury. Protein do leak from the glomerular injury, but the moment patient gets a kidney disease because of the glomerular sclerosis, what we have learned, the Camille-Steele-Wilson syndrome and the nodular sclerosis, proliferative diseases, they could be of two varieties, adaptive kidney disease or non-adaptive kidney disease. If the patient have active urinary sediment like RBC, few cast, have associated hypertension. Hypertension is always marker in diabetes that patient is having proteinuria with hypertension is a part of glomerular pathology. So these patients are to be treated differently. But if they belong to non-diabetic kidney disease, their treatment is entirely different. They respond very well and they do not progress. So you treat like the any diabetes, take care of the, let us take care of the kidney. And they all, IgA nephropathy, surprisingly, which we did not learn before. IgA nephropathy has emerged one of the cofactor, and it's a reversible. It's a treatable condition. It makes a lot of difference, a lot of sense in treating. And some of us could be confusing that this is traditional diabetic nephropathy, which is not. Crescent, post-glomerular streptococcal, vasculitis, these are the well-manageable conditions. So we should treat it earlier. It comes the classical diabetic nephropathy with proteinuria. I still feel starting to begin with an ACE inhibitor would take care of this proteinuria, number one. So it would prevent the progression of the disease. Hyperglycemia, as I said, we start treating sulfonylurea were very cheap initially, but it did not show any renal advantages. On contrary, SGLT2 inhibitor has an advantage. More so, gliptins have advantage. Gliptins have got a specific role on the podocyte, which is responsible for leakage of the protein. So I would be starting gliptin first in these patients because now they are cheap. Lena is very specific, renal is specific in the sense that it has a receptor, that DPP4 receptor is blocked at the level of the podocyte. So I'll go for a linagliptin, and it is not very costly now. And then I would go for SGLT2 inhibitor for two reasons. As I said, it maintains the interior milieu of the loop of the Henle and the isoosmolar movement of the water and takes care of the hypertension. So to me, I don't say practice, the patient I see and write prescription for them, I would be preferring this combination, fixed dose combination, for the prevention of the secondary prevention. Tertiary prevention is a little complicated, so you take care of each and every target organ involvement, whatever that involvement occurs. So for a general physician, internist, endocrinologist, it is better screening of the proteinuria, at least at the time of first appearance. If the patient is very old and follow up for other places, then you do take care of other parameters. Take care if the patient has got microalbuminuria, add gliptin, whatever gliptin is available, cheap and better. If the patient has got profound hyperglycemia, it's better to add SGLT2 because it has a lot of advantages. Now it is available, cheap, readily available. But even sugar lowering capacity of SGLT2 inhibitor is not that great. It's not that high. So we certainly require molecule like sulfonylurea at one time. Otherwise, go for the insulin. So sulfonylurea, I would not throw it away. We are very happy with short-acting molecule like gliclazide, and some of you use glinides also. Now we are not using, but short-acting sulfonylurea. It would not induce any way hypo. And these sulfonylurea, there are a lot of interesting paper also and at the molecular biology level because I'm a little more interested in the basic science. I have that background. So they also have a potential, very tall butamide. I showed it to the one Shashank Joshi. Tall butamide, which I wrote, you may not have written, but I wrote a lot of prescriptions with my teachers. And even as a lecturer when I joined the faculty, Then tolbutamide has been used in experimental animal to cool down, to reduce the beta cell and to activate alpha cell to take the role of the beta cell function with the molecular signal transductions and the transcription factors. So still people believe, very old fashioned people believe, that some of the third generation sulfonylurea have a potential to stimulate some of the dormant beta cell and to get reactivated. So that's the philosophy.
Thank you, sir. So, from what Dr. Bansi said, what Dr. Agarwal said, and what Dr. Tripathi said, that with the studies and with the available of these cheap drugs, there has been a lot of change in the way that we are practicing diabetes. So, this combination of this linagliptin and dapagliflozin and metformin has paved the way for us to, have a cheaper option and a safe option with less hypoglycemia and so many other pleiotropic benefits. So it's wonderful to have this drug. And as Dr. Tripathi also pointed out, in the long run, with whatever data we are having, there is renal safety, there is beneficial effects on the kidney as well as on the heart. So at a low cost, with a less number of tablets, the patient is getting a lot of benefit. So if there are no more questions, Ajay Bhai, I would like to say thanks to Dr. Tripathi, and we can wind up the session.
Thank you.
Right, sir. On behalf of Acmedix also, I thank you, sir. I thank Dr. Tripathi, sir, Dr. Agarwal, sir, Dr. Bansi Sabu, sir, and of course, Dr. Ishwar, sir, for helping, for organizing such a nice program. I also thankful to all delegates who have joined. Almost 450 delegates have joined this webinar during this 1 hour. And even we had a streaming on the YouTube, where also almost 100 doctors have joined to the YouTube streaming also. Sir, Acmedix is always the front runner in helping all academic activities in past, today, and tomorrow. So we'll be always there with you for support of academic activities. Our aim and goal is to offer a very affordable and economic price, even to the newer molecules, like even linagliptin, we have at a very affordable price. We have sitagliptin, we have sacubitril/valsartan, a very affordable price. So that's our aim and goal, and we'll be always there with you in helping the patients also, sir. Thank you so much, and good night to everyone, sir. Thank you so much.